make it go. All right, so welcome everybody. This is the second meeting of the week, and I appreciate all of you that have come for both of them. I apologize for sending the message, the reminder for the meeting that was already passed first today, but at least I noticed it. And so then I sent you a reminder for the one that we're on now, so thanks. This is, I'm excited about the subject. I've seen Ellen's slides and she's gonna knock it out of the park. So thanks again, Ellen Anderson, for your leadership in all you're doing. We are going to have another DCC meeting on the 23rd. You get a week off there, or sort of, yeah. And the Sunday the 23rd, and that's about strategies. That's a really important meeting also. So thank you for all of your attending. We continue to evolve beyond oral health. You're going to see some really big changes coming. Here's a little bit of a sample. We have a logo now. We're talking, we certainly aren't excluding anybody only for dental hygienists, but it is about a vision to change the future of healthcare. And so we're continuing. You'll hear about this rollout as we move forward. As a matter of fact, you can watch for news in our next Smart Bulletin, which will come out. We'll have our DCC meeting on the 23rd, and then our Smart Bulletin comes out that fourth Monday of every month, so it'll be coming out the next day on the 24th. Again, I want to keep announcing, because I'm so excited, that we're getting much, much closer to accomplishing our first goal. On 5/15, we will be meeting at ADA to move on to the next stage, because the chair of the Council on Dental Benefits, the ADA Council on Dental Benefit, Dr. Mark Harian, as you can see there, has said that we will be put on the agenda to bring forward our proposal for a hygienist to be a voting member on the codes committee. So that's a big kudos for our group, because it was all of us that did it. We all had to say the opportunity to put together the ideas. And so thank you again for all of you for being who you are and the efforts that you share here all the time. Also a sneak peek. I mentioned this last time, and actually on Sunday, at our Sunday meeting, this was not necessarily on the agenda, the RDH Under One Roof Beat Oral Cancer event. It's back on the table. It's going to be really exciting. We're going to have fun with it, and I hope and expect and hope that we'll be celebrating the passage of our enhanced oral cancer cancer screening code at that meeting, because it's so important that we really do beat oral cancer, and we can do it together. Our Leading with Kindness breakfast is still on. It will be on the Friday morning of UOR. Details are still pending, right, Patty B? We're still working on getting those details together, but just so you know, if you're going to UOR, it will be on Friday morning. I do want to announce, this is huge, if anybody is in the Florida area or wants to go to Florida, the Mobile Dentistry meeting, the first National Mobile Dentistry Conference, is at the end of this month on the 28th and the 29th in Orlando. One of our insider members, Dr. Mary Kane, made reservations and she can't go. She has offered to give her conference free to any one of our members. It is a sold out meeting. So if you know anybody, if you want to yourself or whatever, you can contact Dr. Kane, as you can do, take a screenshot of Dr. Kane's information there, and or contact me, and I'll put you in touch with Dr. Mary. She's an awesome dentist friend. She's been a good friend for me and my CPR business, as well as this group. And again, that's why she said, please just tell them. Let's see if we can get somebody. That's who I want to offer it to first. So again, if you can be in Orlando on the February 28th and 29th for the Mobile Dentistry World meeting, it's a great opportunity. Also, I want to announce, if you're in Chicago area, the week, a month later, on March 28th, we have coming here to GC America 3 of the absolute leaders in the Canberra, and particularly the absolute experts on silver diamine fluoride. Dr. Doug Young, Dr. Jeanette McLean, as well as Dr. Jeremy Horst are going to be doing a course at GC America headquarters. As you can see the title, Minimally Invasive, Maximally Effective Dentistry Symposium. And what I was told by my speaker mentor from GC America is we can our Beyond Oral Health members can attend it for free. And as you can see, it's a $269 value, but she said I can go ahead and offer it to anybody here for free. Now you can go to the GC website to register, except you're going to probably need to connect with me so I can figure out, because they didn't give me a code yet, because there's going to be a discount code, so it's for free for you. So if you're interested in that Chicago March 28th course, contact me and I will get you the code for attending free. GC America is putting together in their new learning center, they're putting together an amazing level of courses and opportunities. Again, they are bringing in people from all over the country. I'll be giving a course there on March 6th. Of basic life support. Lisa Schmidt will be offering that. I'm doing an oral systemic course in the morning, and in the afternoon you can get your CPR certification also. But what I'm showing you here is to go to GC America's website, and that's where they have the listing of all these courses. Again, get a bargain by contacting me and to get all those courses. I also know that the Illinois Dental Hygienists Association is having their state meeting there in November. It's not on the schedule yet, but it'll be there in November. More to come. And again, GC America is a longtime sponsor of mine as well as Beyond Oral Health, and we really appreciate all they do for us. Our next study club, let me talk about it. Well, I'm not actually going to talk about it. I'm going to tell you the date, and then I'm going to ask Susan to tell you all about it. So it's on March 16th. It's a Wednesday that time. And Susan, are we going to start at 7 o'clock or 8 or 6 o'clock your time?
Yeah, 6 o'clock my time. 7 o'clock. Yep.
7 o'clock Central. So why don't you tell them about what your course and what we're going to do next time around?
Well, hopefully we'll be able to let you know about a new code, right?
That's right. We'll know by that Wednesday. We'll have been decided the Thursday before. Awesome. Yeah.
So we're going to talk about all things oral cancer and screening. And, I like to focus on, it's more than what catches our eye. It's a lot of what we need to put into our health history, and it's different things that we need to be aware of. It's not just looking for lesions. There's a lot of signs and symptoms that we need to be aware of. And we're going to talk about that enhanced head and neck oral pharyngeal cancer screening. And we'll talk a lot about the oral pharynx and how do we really screen thoroughly for that oral pharynx and documentation.
Terrific. And of course, Susan was our leader liaison of our oral cancer work group. She's also the co-chair with Allison Stahl of our event that we're going to have at Under One Roof. She's an amazing leader. For anybody that was on that work group, I think they all agree with me. Susan is an amazing leader. And so again, oh God, I'm so excited. Yeah, we'll be able to announce it there. So, okay. Thank you, Susan. Now moving forward, of course, this is our study club, is our think tank, and in order to give you ADD PACE credit, we have to do things a bit differently than we'll have to ever do again. That can be differently than what we've done the other time. In order to get CE, I need to have a course description, I need to have objectives, and at this point in time, you need your name. You don't need to put your email in the chat box unless you're new to dental code to Beyond Oral Health. But put your full first and last name in the chat box because that's our attendance roster. I will announce, though, that we have, as of just an hour or so ago, I have moved my subscription from GoToMeeting to GoToWebinar. And the good news on that, the invitations are going to look different. The confirmation is going to look different. The keeping track of CE is going to be different. And Susan, in a good announcement for you, we're going to be able to do videos with using GoToWebinar. I'll tell you more about that later. So because before we had the limitations that if we used videos, you couldn't hear the sound. With GoToWebinar, we can also use video. So because we're still on the old platform, though, what I'm going to need to do is we're going to go and we're going to do some attendance here. So I think it says, again, how many people do we have signed in at this point? We have 15 people signed in. So Lindsay, you're going to have to watch them as they come in after this, because Lindsay's keeping track as we go through the names. So first, let me recognize, if I can get this thing to change. Here we go. Barbie Lynch, are you here yet? Barbie, she said she might be stuck in a staff meeting. How about Carol Jackson? Chris Maiello? Krista McConaughey? How about Connie? Is Connie here? Connie? No? Okay. Debbie Galuppi? Diana Corbin? Oh, we're shooting 1,000 here. Ellen Anderson, you better be here. Say hi, Ellen. Ellen?
Hi, I am here.
There you are.
Did I
Good.
make-
Since she's the presenter tonight, and all I'd be able to do is show you slides. I wouldn't know the words that go with them. Anyway, Erin Hendricks. Gayleen, I think I saw you come in. Hey, Gayleen.
Yeah, Patty.
There she is. Ivy Welchuk. Not yet. Jean Wentz. Michelle, say hi. Michelle Race.
Hello again.
Perfect. Jennifer Bruckner. Jill, I think I saw you come in. Hi, Jill. Jill. Hey, Jill. I see her there. Okay, how about Wynette Davis? Karen Siebert? Catherine Palulo?
Hi, how are you?
She gets an extra 20 minutes of CE because she got on really early.
I know, because I was afraid I was going to have trouble like I did Sunday night.
Oh, okay. Okay, well, we're glad you're here, Catherine.
Yeah,
Layla?
thank you.
Layla?
Hi, y'all.
Hi, y'all. Linda Venzer? Lindsay Hill? Mark yourself as present.
Hello.
Hey, there you go. Make yourself as present, Lisa. Lisa Simonson.
Hello.
Lisa, I always put an extra syllable in your last name. Sorry. How about Liz Neese? Liz, I talked to Liz at 8:00 this morning. I don't see her here now, but okay. How about Mary Margaret Pierce Lambert? Boy, she's what a lot of names there. One of the things that's great is this is, by the way, if you're not familiar with this credential, this is a fellow in the American Academy of Dental Office Managers. So this is somebody that's gone through a certification program as a certified office manager. Thrilled when we see people of all types and of all backgrounds in dentistry join us. Amy McClintock. Amy, are you here?
Hello.
There she is. Kim Jockheim, I think I saw you come in.
Yep, I'm here, Patty.
Hey, Kim. Linda Keltner. Not yet. Okay. Nancy Brohan. Is Nancy here yet? Oh, I was hoping to ask her if she retired. How about Nicole Fortune? Patty B, you're gonna manage the chat box, right?
Yes, ma'am. I'm here.
Terrific. How about Patty Korecki? No? We've got another Patty up. Patricia Mulford. Are you a Patty also? Nope, she's not here yet. Patty DeAngie, I'm here. Rebecca Van Horn. I don't see her yet. Rhoda, are you here, Rhoda? Robin? How about Robin Rixey? Susan, say hi again.
Hi again.
Sylvia, I see Sylvia here. Hi, Sylvia. Say hi, Sylvia. We're doing attendance, sort of. I see your name there. Teresa Shepard. Nope. Okay. All right. So your CE, there's your CE certificate for it. A 1-hour lecture. There's actually a subject code in the AGD list for special patient, which I was thrilled to see, Ellen, that we have the accurate code. So make sure your first name and last name is in the chat box so that we can make sure that you are accounted for in our CE records. So this is a safe place. It is a think tank. When I say it's a safe place, what I mean is that you are welcome to ask questions Ellen's going to have some questions she's going to ask you, but if you want to ask Ellen questions, please feel free to. Let's not keep all our conversation in the chat box. Patty will monitor it, and she will make you say it out loud anyway, right, Patty? So without further ado, here is Ellen Anderson, a dear friend of mine who we've gotten to know each other in I don't know how many years, because I went to school with one of her friends. We went to school a million years ago, and Ellen and I have been on parallel and intersecting paths for many years. And she is really close to retiring from full-time clinical and more, but I'll let Ellen tell you a little bit more about her. So take it away, Ellen. I'm going to give you the screen now. All I gotta do is remember how. Now I know how. Ellen, I'm getting there. We practiced this already, so we know it works.
Okay, I'm waiting.
I haven't clicked it yet. There we go. I'm getting there. Make presenter. Yes. Okay. So you got it now, girlfriend.
I do. Okay. Share. Okay. Is it coming up? Okay.
Yep, it's there.
Okay. Now I gotta hide you. You're right there. Okay. Bye-bye. All right. Well, thank you everyone for coming, and thank you so much, Patty, for having me present tonight. This is my passion, which I didn't know I'd have one, but I'm going to talk a little bit about what I do pretty much every day when I go to work. And it's a program that we more or less put together called Creating Successful Dental Visits, because we want everyone to be successful, not only the patient, but the providers, the caregivers, the families, everybody involved. And there's a few methods that we've put together. I've been working with special needs for the last, I want to say 10 years now in some fashion or another. And my current clinic, working with special needs, I've been there for 9 years. So let's go to the next slide. Okay, so who are special needs patients? Well, the CDC says that there are 10 million Americans that live with a developmental disability. And the United Nations has reported that more than 500 million people worldwide live with some type of disability. And the American Dental Association actually defines what a special needs dental patient is that they require special consideration when receiving dental treatment because of their developmental or cognitive conditions. And this can include ASD, which is autistic spectrum disorder, Alzheimer's, Down syndrome, or any condition that makes the procedure more difficult. And I'm here to tell you the list goes on and on and on. There are, I had no idea how many different diagnoses you can have with special needs. So these are the types of people that I see. They range from extremely difficult to easier than any other patient I've ever saw. So there definitely is a difference. Okay, so why should we care? Why should we care about people with developmental disabilities? What's the deal? First of all, this is a population that has a significant unmet oral health care need. In terms of unmet needs, oral care ranks third for special needs individuals, just following residential services and employment opportunities. So they seem to have a little bit better access to medical care or maybe entertainment or anything else like that. But third, it ranks third in their needs. People with special needs are very high risk for dental disease and can just open it up for discussion. I don't think it goes without saying that they're really not that skilled or able to follow directions to be able to do their own self-care. And I'm not saying everyone, but a great majority of them. There's also at this point in time, and Patty and I talked about this, the life expectancy has really increased. So no longer do we have people. Uh-oh, now I'm getting feedback. What's going on?
It's me. I'm working on it. Sorry.
Okay. You know, we have an aging population of people
Shut
who are
up,
getting,
phone.
but we also have special needs individuals that are getting older. So now we have a whole new population of people with a whole new set of needs and concerns. In fact, my oldest patient where I work is 83 years old, and she's a pistol. It's when we tend to think of special needs, we tend to think of Special Olympics, young people, you know, just having a great time. A lot of volunteers doing screenings. I think that is, you know, the kind of the idea of what we think of special needs dental patients, but it's way more than that.
And
Also,
if I can interrupt you, Ellen, aren't these the same people that I saw when I was in hygiene school?
yes, in fact, the ones that you saw in hygiene school are now senior citizens.
Yeah, yeah. Hello.
Yeah, they might have been young adults or kids at that time, and yes, we have folks where they live that went to Harper there for their dental appointments and just to come on over and help the students out, however they felt. Yeah, they're still living there.
Mm-hmm.
But the other thing is, this is not just like a residential area where, Patty, what you're referring to. There was a shift back in the 80s, 70s, and 80s to deinstitutionalize people with special needs, because at one point in time there were quite a few state residential areas or hospitals, whatever term you want to use. And with that, they would have on-premises dental and medical care. And when the state changed all that to decrease deinstitutionalization, there went their oral care. So now they're out in the general public, living in community homes or back home with their parents. And where do they go for care? They no longer had that opportunity when they were in an institution. You know, I'm not here to talk good or bad about institutions. It's just that this increased the need in the general population. Also, there's low expectations, fear of dental treatment, and lack of awareness of the caregivers. Caregivers, that's the last thing on their list that they want to do is take someone to the dentist. There's other things. They have financial issues, meeting different programs, signing up for all sorts of programs that could aid in their daily life. There's a lot of things that a caregiver or a parent has to go through when they have a loved one with special needs. Poor daily oral hygiene is definitely an issue for most people with special needs. And the caregivers and their parents, and I get it all the time, they're afraid of getting bit. They don't want to put their hands on anybody's mouth. They don't want to put a toothbrush in their mouth. Diet, medication, oral habits, and access or denial of services is very, very big for this particular population. One of the things that I found as I worked where I'm at, we've got a lot of people in their 20s coming to us, 20s and 30s, and they hadn't been to the dentist for a while because they had been seeing a pediatric dentist and they aged out. Once you're no longer a child, a lot of the pediatric practices no longer see the adult person with special needs. I'm not saying all of them, but a lot of them do. And currently, right now, all of the policy and regulation for caring for dental patients with special needs is under the American Academy of Pediatrics. And that was one of the things that I found really interesting when speaking to parents who have a 45-year-old son coming to us, and everything is in language that says your child, or the child this and the child that. And it's like, this is an adult. This is no longer a small child. You know, it might be their child, but when you're talking to people, you don't talk to them like as if they're children. Anyway, I could go on forever about that. Public aid, a lot of them are on public aid or low income, and they don't have the ability to pay for services. There's also inadequate education and training for dental providers, which we will address a little bit later on in the presentation. And along with the low level of confidence that some providers may have in treating people with special needs. So I can open it up to some comments. Any other reason why we should care, or we can kind of go on to my program that we put together.
Keep going.
Okay, so, all right, desensitization. This is the word here that Patty said. What do you use? Gluma, fluoride. What do you do to desensitize your patient? And it's like, no, Patty, that's not it. It's a word that the dental profession, and it's in the American Academy of Pediatric protocol of to desensitize is to have a person with special needs be so comfortable or in a dental situation where it doesn't bother them. Okay, so if you look at the word desensitization, our kids are desensitized to a lot of things because they see so much in the media. A lot of things we just know are just everyday occurrences because we've heard so much about it, it no longer shocks us. But I like to take it a little bit further and add the familiarization. Now this gives it a little bit more of a friendly feeling. So when our patients come in, they need to feel like they understand the building, the room, the people that are working in our clinic, the tools that we use, the smells that it has, all sorts of things. Not only do we want to desensitize, we want to familiarize. We want to also take a look at the expectations. What do we expect from this patient when they come in? And what does the patient and the caregiver and the parents expect of us? So we kind of all have to get on that same page of knowing what each other is looking for and also what each other is able to give. Acclimatization. Okay, after a while you go somewhere, you get acclimated to it and you're used to it and you're able to function within that environment. And then participation. One of my biggest philosophies is that when I see a person with special needs for dental care, I don't want them to be a passive recipient. I would like them to become an active participant. And that is pretty much the backbone of the program that we came up with. And with these things, these 5 words in mind, we have success, or most of the time. So there's plenty of room to add more building blocks to the success story. But for right now, it's with at least these things, we do have a lot of success stories. Just the desensitization, it's really easy to give up. Okay, so when we're preparing for a creating successful dental visit appointment, one of the things that, of course, is teamwork. The first person that they see when a patient and caregiver or family member comes into the building, you need someone that's going to be friendly and greet them. And that goes without saying in any dental office, no matter what. But that person up front has to be able to not be shocked at some of the behavior that they may see or some of the questions that the parents may ask that are a little bit off center from other things that we may normally see. The building really needs to be somewhat special needs friendly, not a whole lot of stuff going on, not a lot of open space, not too much clutter, not a whole lot of noise. You got to keep your waiting room down to a little bit of a minimal. And when there's too many people out in the waiting room, it's really, really, really frightening to some people, and it can raise a level of anxiety and fear. We like to have large washrooms because you may have a wheelchair, or you have to have more than 1 or 2 people to going into the room with a special needs person to assist them. You want your chairs to be wiped down because be able to wipe down your chairs because sometimes we have accidents out there. So nothing with fabric. clean, uncluttered countertops, and just your environment. You know, it just kind of makes sense not to have too much stuff around, but you want to make sure that it's friendly. And I have some pictures later on in the presentation to show you what we have. So part of the success too is when a person calls to make an appointment for their loved one or their clients that have special needs, there's a very important intake interview phone call. So I know all of you know, you ask, you know, the phone number, the date of birth, and all that other information, but we need to go ahead and ask questions like primary diagnosis. When was their last dental appointment? Was it successful? Are they, you know, what can you tell us about the last dental appointment you had? Is this person ambulatory? Do they use a wheelchair, walker, or a cane? Are they sighted? Are they verbal? All sorts of things. And of course, is there any pain going on? What is your chief concern? So, if, you know, because of all these questions, the right type of appointment and appointment time can be made. Let's see. Also, we ask if they would like a social story, because we can print pictures of our clinic, pictures of our providers, and add a little story to it. So before a person goes or comes to visit us, they can be familiar with who we are and what we do by seeing a social story. We also have something called a get acquainted visit. They can come in. Absolutely no dental work is expected to happen on that get acquainted visit, but if it does, that's great. The person only walks through the door and takes a look around, gets to meet everybody. We do a lot to encourage that person to feel comfortable and want to come back. Try to get them to sit in the chair. If we can go ahead with either a screening or an assessment, or if we can go ahead and do a full exam, which has happened many, many times, that's what we do. And of course, an individual approach. The get acquainted visit and the intake interview also helps us to assess that person's needs. We want to know how they communicate, what's the best way to go, what things are they rewarded with, so that when that person actually does come in, we know exactly how that appointment's going to go. So if a parent says, yes, my son loves Lionel Richie music, he just absolutely love it. When that person comes in, Lionel Richie music is being played. If somebody likes to, they like kittens, we have stuffed animals with kittens or pictures with kittens and things like that. So the more we know that person, what to expect of them and what they're all about, the more we can prepare for them. And it's just amazing how that really works. And I'm sure I'm preaching to the choir here. We all know this. But let's take a look what's in our own personal skill toolbox. The number one thing of anything is patience. And if you don't have patience, working with special needs people is not for you. Flexibility. Being mission focused is not going to get you anywhere. If you have to use a Profi cup first before you use a scaler, that may be your flexibility area. Not only emotionally, professionally, but physically as well. There's some very interesting ergonomics that go on when you work with people with special needs. Creativity. All I can say is that that's a big one, and you have to think of things on the spot. Voice control. You have to be very self-aware of whether your voice is too loud, too soft, too demeaning, too demanding, too sugary. And knowing your patient, what they have, sometimes you want to be very serious with them. Sometimes you want to be a little friendlier, joking around a little bit, but you find all of this out through the intake interview, through the caregivers, and also just your observation. You need to be able to have positive body language, and you only can get positive body language if you're comfortable with what you're doing, and a willingness to connect. When I took the position where I'm at right now, the previous hygienist told me, Ellen, the biggest thing I can tell you is it's all about relationships. And the funny thing is that I remember all of my patients' names, what they like, what they dislike, and I can't say that about previous practices. I know, oh, you know, that person with the crown on number 14, and you know, they drive that car. That was all when I worked in private practice. That's how I remembered people. I mean, except for maybe a few. But with the special needs people, it is amazing how we know exactly who they are, what they look like, and what they like. And another thing is you have to leave your ego at the door. You cannot be to the point where it's going to be my way or the highway. And again, that goes with flexibility, but you can't take anything personal. Sometimes it just doesn't work the first time. Sometimes it's just a bad day. And at that point, you need to say, okay, I can't take any of this personally. My ego is not going to be bruised. You just keep going and go on to the next moment. Tools of the trade. You like this one, Patty? Very first one is toothbrush.
Yeah.
It has to be a toothbrush. It is the magic wand. One of our medical providers came and asked me when he was trying to look at someone's throat, because they brought him in because he was they felt he had like a sore throat or something, and he the child wouldn't open up his mouth, and he comes in and he says, do you have some kind of magic tool to have somebody open up? And I said, I sure do. I gave him a toothbrush. And as soon as this child saw the toothbrush, he opened up his mouth, and they just thought this was a miracle. So, but most people, when they see a toothbrush, oops, got to go back. Most people, when they see a toothbrush, they know where it's supposed to go. Communicators. Let's see, what I have here is kind of hiding my screen here. Let's see. Communication. With working with special needs, you need to be able to know their language, whatever that may be. Sometimes it's body language, sometimes it's sign language, sometimes it's no language at all. But being very, very attuned to how they move, where their eyes are looking, what they're seeing, what they grab, and this is the language that you need to know. Most of us do as hygienists. But this is a different culture. This is a different type of person. It's almost like as if you were going to Europe, to a country you never heard of before, but you want to make sure you know what's going on. You would read about that culture. You would learn about their language, and there's a lot of languages in the special needs community. Sensory redirection. This is when okay, so the more we talk to a patient, they're listening to us and they're not really knowing, what they're feeling. Let me see here. I've got a paper on this because I can't really see what my screen says. Okay. Sensory redirection could be anything from music, aromatherapy, turning off the lights, having different lights, talking, whispering, counting.
Ellen, can I stop you for a second? When you're talking about aromatherapy, you're not talking about stinky stuff you put in the room. You're actually certified in in Aura Spa peri-aromatherapy from Deb Grant, correct?
Yes, but I don't do it under her program. I have the background to check medical histories, and I know the different types of aromas to use, but I'm not using her
right,
program.
but you have had the training. I just felt like we needed to jump in there because I'm an allergy person, and yeah, I don't know if we couldn't call it a special needs, but I sure know that I would get sick if somebody uses stinky stuff that they think smells great, and it's just a non-therapeutic type of aromatherapy.
Right. And no, we don't do that. This is and we don't use it if it's contraindicated for that person. It's not being used, and it's not often used, but sometimes it does help. Let's see. I'm sorry, my eyes are getting bad. Adaptive devices. We use something called an open mouth wide rest, made by a special care company. And this is something that is very, very user-friendly, and the patients aren't afraid of it, and it just kind of helps them open their mouth and stay open. This Bluetooth equipment, I love my my cordless Profi cups, because sometimes people don't want to sit in the chair, or if they're bending around or moving in a different direction. Of course, a lot of times these movements are involuntary, and your cord may not reach that far, or your cord will get in the way. Or sometimes I take my Profi angle out to the waiting room and just show the patient what we're going to use, and use it right out there in the waiting area or out in the patient's car, just to get them more comfortable and more familiar with what's going on inside the dental clinic. There's something called protective stabilization, which I'll talk about in a little bit, and positive reinforcement. You'll notice my opening page had the high fives, a lot of high fives. My hand has never been slapped so much in the last 10 years as it has been in my entire life, with high fives, high fives, high fives. And of course, rewards. A lot of positive reinforcement by saying, "What a good job, great job, let's do that." And then we have rewards as like a prize box, or again, whatever that person likes. I have one lady who wants a cup of coffee when she's done. Another one wants a magazine. Another one just wants to have a phone book. Whatever they like, and if they've done a good job, they get their reward, they work for it. Okay, here's a picture of our sensory room, our waiting room. I kind of want to throw this in. Now, I know not everybody has the space to do something like this, but this is where our patients can wait for their dental appointment and feel comfortable. We've also done some exams right there on those beanbag chairs. So just a little bit of what we have. This is special. I realize that this is not everyone can do this. So this is my average clinical operatory. Nothing special about it at all. There's just a regular chair and nothing special whatsoever. Whoops. But here's our prize box. Okay. We make sure that we try to get things into the prize box that someone would really value. Special needs people, they don't, they're not going to go for something like plastic or one of these little put together airplanes. That's not a reward to them, but they love things like Hot Wheels or just little fuzzy things to touch, stuffed animals, jewelry. It just depends. And then some don't want any at all, but a lot of them will do whatever it takes and really be a good participant to get their reward. Communication methods. This little story, the social story of getting a filling, is made up of individual pecks. These can be put together in a story like this, or you can just use them one at a time on a ring. And it basically is a communication system, mostly for people with autism. They understand the very, very simple illustration. Another very common type of communication is if people are getting pretty anxious and they're thinking, my time in the dental chair is like, I want to go home, or I want to go swimming, or I want to go to McDonald's. It's the first then. And this is a very common communication that a lot of schools for special needs use, different facilities, parents, and it's always first dentist, then home, or first dentist, then pet store. Whatever it is that they are going to do after the dentist is put into the then, and it's very simple. There's two things. It's dentist and then wherever. So it's something that we found to be very, very helpful. One of the philosophies that we have is teach before it needs to be taught. So most of us as mothers or parents, we may have tried to teach our children how to tie their shoes before they went to kindergarten, because it pretty much is expected to know how to tie your shoes in kindergarten. You need to be able to tie your shoes or put your coat on or whatever to be able to go out into the snowstorm, or if your house is on fire, and that is not the time to teach your child how to tie his shoes. So to teach someone how to behave and to participate in a dental chair is not when there's a dental emergency. That is not a good idea. So you want to start this off in the beginning with a calm environment with no pressure. Have that person, give that person the opportunity to explore. Again, have patience. I can't tell you patience, patience, patience. Also, reteaching parents on a few things, and also learning from the parents. The parents, caregivers are a wealth of information on working together to make it successful for the person with special needs in the dental environment. Okay, so everyone pretty much is familiar with the show, tell, do method, where you show them or tell them and show them and then you do it. Well, this is 2.0. So sometimes you have to show them and tell them and then do just entering the room. Entering the room, believe it or not, is a really, really difficult thing for a lot of people with special needs. And when I see adults that won't enter the room, it's pretty obvious that they have had previous traumatic experiences. They have been traumatized beyond belief. Just to be able to sit on the chair, they look at that chair and they go, no way. So if you can get them to sit on the chair and get used to going up and down and back and forth, sometimes it takes a good 15-minute appointment just to get used to the suction in the air and water syringe. Now you're thinking, well, why would we want to spend all this time? Well, once they're used to it, they're good with it. And 15 minutes of our time to go ahead and work with the patient rather than giving up and then referring out for general anesthesia is kind of my thought, that I think it's a little better to spend time to do this desensitization program rather than just give up right away because a person is not just cooperating with you. Okay, the sensory redirection, we talked a little bit about that before with music, lights, aroma, video. Sometimes a person needs to be continuously watching a Barney video or some Blue's Clues, something like that. And as long as they're focused on that and they're able to go ahead with the dental work, the more we do that, the less they're focused on the video and the more they're interacting with us instead. Deep pressure. This could be where we can put a weighted blanket on someone, or just even resting your hands on their shoulders and very gently pressing down. A lot of times this is all a person needs to get the anxiety of all of the environment that's they're trying to filter through to have them come to some equilibrium. Heavy lifting. I don't make my patients move the furniture around too often, but sometimes that flexible wipe down chairs in the waiting room, if I have a young individual or any individual with that I can see is just having a very difficult time calming down, I'll ask them to move the chairs around. And they will. I'll say, put that one over here, put this one over here, move this one there. Now let's do it again and let's put it back in order again. And just by doing that physical activity, they have released a lot of their anxiety through movement and pushing. Counting. Unbelievable what a wonderful gift counting is. You say, okay, we're going to count to 5. 1, 2, 3, 4, 5, break. You do this repeatedly so that when you are trying to do something, whether it's counting their teeth, brushing their teeth, anything any type of procedure you're trying to do, they know there's going to be an end. A lot of times people with special needs they're so in the moment, they don't realize that this is going to stop at some point. They want to stop it. So if you say it will stop at 5, they're more likely to cooperate with you. We have nothing. We have no shame. We'll sing. We'll see Going Around the Mountain. We'll see the ABC song. Any song that a person likes, we will sing it if that's what will make them happy and cooperate with what we're doing. And talking. A lot of times we're just whispering in their ear, kind of a tingling type of thing. I know that there's a lot of this going on where you can listen to people talk very, very softly, and it's supposed to calm you down. The ASMR, it works. I will start talking to somebody and just saying, well, whatever it may be, just whispering. And all of a sudden, they're just real calm, and you just continue doing that, and they're fine with the procedure that you're doing. Okay, I want to talk a little bit about protective stabilization. People need to be desensitized against this too. This can be a controversial subject because a lot of people will look at this and say, no, I don't want my child wrapped. I don't want my loved one wrapped. Then I have others ones who say, can I get one of these at home? Really, it is a very nice, soft Velcro wrap. We call it the big hug. And you get people used to it first. A lot of the people that we have that started off needing it so that they wouldn't jump out of the chair, they request it. They'll sit down and they put themselves in the position to have the big hug, and they're happy. It is not, we never force anyone to go into a rainbow wrap. It provides a security that, like, when the chair is going back, they're not going to fall out. It's like if you were going to go on a roller coaster and you didn't wear your seatbelt. We have to put ourselves in the position of people with special need who perceive their world a little differently than we do. The center picture is showing the use of a, I'm not sure about that instrumentation, but the white prop there is called a open wide mouth rest, or we very affectionately call it the marshmallow stick. And this is basically, it comes out like a popsicle stick. The patient could hold it themselves just to help them keep their mouth open, because you wouldn't want this young child to bite down and get stabbed with the end of that sickle scaler. Then the picture over on the far right is what they call a molt mouth gag. I hate that name. We call it a helper. And we hand it to our patient and say, do we need a helper? Okay, let's show you the helper. We let them hold it. We let them look at it. We let them put it in their mouth. It's familiar to them. And it's like, okay, let's show you how it works. And we have we have no resistance when we use this. And when you look at it, it looks kind of scary, but it's extremely helpful because you're not going to have somebody accidentally bite down on your instruments or your finger. Talking a little bit about the rainbow wrap and the protective stabilization, there is a whole protocol written in the American Academy of Pediatrics on how to use protective stabilization and when it's indicated, and it definitely requires education and training. And it goes over the techniques, the equipment, the monitoring, the indications, and the contraindications. There definitely are contraindications to it. The risks and what needs to be documented in the chart, and absolutely have to have signed consents by a guardian or parent. This is not something that you can just use. And the training is about 2 hours. There's an hour of video and kind of back and forth testing, and then there's the hands-on. And there, believe it or not, there is a technique to putting this on correctly. So, you know, you don't use it lightly. You're always making sure that nobody is being hurt, nobody is wrapped too tightly. And you can see by the picture, this is one of my patients. I do have permission to use her picture from her mother. She's not in distress at all. In fact, she's one of those that sits down and says, okay, let's wrap. Okay, so with success comes a deal. You have to make a deal. A deal is an effort and a commitment from all parties. So in order for this program to work, we need a commitment between the dental team and the patients and their families, the dental team, the patient, the caregivers, the agencies that we see our patients from, the facilities that they come from, third-party payers. That's kind of that's part of the deal too. And your staff, the providers and the whole dental staff. So it definitely is something that everyone has to be on board with for the best success. Okay, getting back to good care. When we see patients, we also do an individualized care plan for them to take home with their caregivers or their family. It's written instructions, also written orders for devices and strategies that they can use at home. So there are things that you can modify your toothbrush with. There's plenty of adaptive devices for oral care that can be found. And we as dental professionals, we can basically assess which are the best to meet a certain person's needs. The frequencies of visits with people with special needs, I often see people once a month for hygiene. Rarely can anyone go more than 3 months without having chronic gingivitis. And you want to communicate between the medical team, the school if there is one involved, parents, guardians, administrators. There has to be open communication in order for this to happen. Okay, I'm putting up a picture here of two of my patients, and these are area concerns that you would point out to this care staff or a parent. And believe it or not, the parents and the caregivers didn't know that there was a problem here in either one of these pictures. So a little bit of red around the gums, didn't even take notice. And this picture on the right, they just thought he was born with that kind of a tooth. It was just the teeth, the enamel was all fused together. Oops. So it's interesting to point this out. You do have to educate the people that bring these folks in. Okay, so what are the benefits of desensitization? And this is where I'm going to open up for some questions and some comments. To see, I had said something before about maybe taking a 15-minute appointment just for someone to get used to the air water syringe in the suction tube, or to be able to sit in the chair. Is there a benefit to doing this rather than immediately always or just routinely sending people off to be sedated to have dental care?
I think the obvious answer to that is yes, of course there is. Is there anybody that's doing any of this kind of desensitization in your practice right now? In any settings that you're working in? I'll call on you. I'm getting my list.
I worked, this is Michelle, I worked with a lot of this kind of clientele when I was in general practice. I'm in perio, so I just mostly see adults, some, no, not really any disabilities, but general practice, yes.
Thanks, Michelle.
Hey guys, this is Denise Arsky. So when I was practicing, I worked for an office out in Bensonville, Illinois. And when I was working there, I had a patient, her name was Jackie, and she was in her late 20s, and she was significantly on that spectrum. Her mom would bring her in, and for some reason, just being, again, quiet, letting her make those moves, letting her tell you pretty much what her fears are, just watching, not necessarily being able to speak it because she couldn't do that. But while I was working on her, her mom at the end of the appointment stopped and squeezed me so tight and said, I cannot believe the amount of time you took with her, the care you took with her, because no one else has. No one else has cleaned her teeth the way you did. No one else has done any of this. And it is about taking your time and really focusing on the needs of that person. I was in a situation where the doctor just said, here's your operatory, do what you got to do in there. And, based on trust and knowing that what I do for him his patients were going to benefit. So I didn't have to worry about somebody standing outside the hallway, looking at a watch saying, hey, listen, you're 20 minutes into your next person's appointment. I never had to worry about that, because if somebody was waiting, then somebody in the practice would grab that next patient, put him in a room, start taking any necessary radiographs if that's what the doctor wanted to do, or start the procedures for me so that I can continue doing what I needed to do. But when you have that mom get so, she was emotional, cried that no one has ever spent the time to do this, because that's the key to what you're explaining, is that we're all human lives. These are human beings that can't express what they really want to express. And we don't want them to suffer any undue, stress that they don't have to. And if we can eliminate some of that by making them healthier and happier, by their mouths being cleaner, not having to go through so many fillings or sedations or treatments, because we've cared for them the best of our ability and they come in every month like we ask them to, that's what it's all about, that feeling that we've done something the right way to make somebody feel better and live better. Sorry, I had to do my whole story.
Thank you, Denise. Thank you very much for that. Ellen, can I ask you a question? That was one of the things that I wondered about, is time. How do you schedule?
We schedule about a half an hour, but if we go over a little bit, it's okay. And we know when we can kind of say, okay, let's continue this. Can you make an appointment for next week? But we have at least a half an hour. Sometimes I have an hour. Take as long. We also know who needs more time. That's another part of making it successful. So if we know we're having Tommy come in, and Tommy really takes a lot of our time, we didn't know this maybe in the beginning, but you assess it, we kind of see what's going on. You give him an hour, and then you have like a 15-minute downtime afterwards to decompress after how much screaming this kid does. And it's not like he's screaming because he's in pain. That's how he communicates. And it took a while for us to understand that he's just happy. And when so yes, the schedule is totally flexible and accommodates the needs of the patient of where we're at, and it works out real well. Now in private practice, it's impossible to do that. And I'm not saying that's a bad thing. It's just you can't do that and keep your doors open. So, but Denise, what you're saying, this is why I work there. I have parents that are in tears, and they just say, "Oh my gosh, I can't believe you guys got this done." We have people coming. Okay, well, I'm based in northwest suburbs of Illinois, and we have people coming 100, 150 miles to come and see us. And they say no one else will see our patient, our son. No one will see our clients. And it's just the most amazing thing that happens. So that's a personal benefit for me, and I'm sure for you as well, when you have that. But I think in the long run, what about financing? You know how much it costs to run an operating room, to put somebody under general anesthesia just to do a cleaning? And I don't mean that in a negative way, just for cleaning.
Did you use the C word? Excuse me. Use the C word, Ellen. Come on, you knew I was going to jump on that. I think Layla has a very interesting question in the chat box. Layla's asking, what do you suggest for patients who may want to touch you too affectionately?
Oh, okay. Yes, there are boundaries. Yes, you say nice hands. Nice hands. Hands to yourself. Keep your hands on your tummy. Keep your hands, fold your hands. It's constant reinforcing. And you're right. I can't see the chat box, so I'm not sure who asked that, but very loving population. New patient came in just this afternoon. I didn't even see her. Her brother was in the chair and the doctor saw her. The little girl just came up and she just wanted to give me a hug goodbye. So you have to kind of decide what's too much and what isn't. And this is a safe place here. I have patients, male patients, that get in the chair and they get awfully excited when you clean your teeth, and you have to stop and say, not here. And I'll say nothing more. You just leave that to your own knowledge. But yes, they'll touch you or themselves in a little too affectionate.
Affectionately. Okay.
Yes.
Thank you for
Oh,
that.
and I have one individual who has a shoe fetish. When you know that somebody has a fetish, you don't feed it. And he will constantly want to talk to you about your shoes. And he has been known to chase people down, especially women, to chase them down just so that he can look at their shoes. And but he knows when you redirect him. There's a lot of redirection.
Which also takes a
I hope
lot of
that answers.
patience.
Yeah,
Lindsay
I hope that
Lindsay has something in the chat box. Lindsay, can you share with the
Hi.
Mhm.
Yes. Yeah, I don't know too much about it because I don't have too much contact with my brother anymore. But yeah, my mom told me stories of my brother when he was probably younger, a teenager. He's in his 40s now, but he like refuses to go to the dentist. Like, I don't know. I asked my mom the other day if he's been. I thought about him, and she's like, I have no idea. I doubt it. She remembers taking him to the dentist as a kid, and she was like, it was horrible. Like, he got very aggressive and like really mean, and there was like a situation, and then after that, going forward, they had to put him under for anything, and they tried to do other things as needed, like if he needed a cavity, or I'm sorry, needed a filling or anything, it was a whole thing. So, and he only did it, I think, once or twice a year when he probably needed to go like you said, like once a month.
Yeah.
So yeah,
No,
it's a real thing.
Was your brother normally aggressive in other situations, or just when he went to the dentist?
Certain ways, yes. It would depend on certain things. Overall, no, but yeah, certain things would irritate him just day to day, and he would tend to get aggressive, but he knew how to like control it a little bit. But with that, it seemed like he just like saw fire. Like, he had no way to like stop. Yeah.
Yeah, and that takes training on the professional side as well. There's something that I have the very good fortune of being able to be trained in CPI training, which is something that helps you to diffuse a situation like this. And that does help so that you know how to respond when somebody is starting to get aggressive. And but we don't take it personally. It's like, okay, we understand this is not something that you're having a good time with. So we do have people like that, and we work with them. We get them back again, and like, okay, again with the familiarization, then they become a little bit more calm with us. So we had a lot of positive experience with that, but we also have some that still we're working on. Where there is no successful dental visit just yet because of aggression, and we don't want anybody to be get hurt in any way.
You said the training you took was CPI. What does that stand for? Sorry.
Yeah, I knew you put me on the spot. It's a okay. Let me look at because I know what it stands for. Training is a crisis prevention intervention.
Okay. Terrific.
Okay, so it's basically you learn how to see when something's escalating, because before someone really loses control, there are signs beforehand. So it teaches you how to recognize that and then how to de-escalate as it goes on. So
terrific.
Go ahead.
Okay, so let's move forward, Ellen.
All right, let me see what's next. Okay, so creating successful dental visits goes both ways. We kind of talked about that before with like I said, with the crisis de-escalation training. First of all, we need to be desensitized. Okay, the more exposure that we have with people with special needs and difficult to manage patients, the more comfortable we become, the more secure we feel in our ability to treat people. You want to familiarize yourself. I can't tell you enough how many books, movies, magazines, articles I've read about the different cultures. You'll never find a more diverse culture of people than people with special needs. And the more you know about it, the more you're able to feel comfortable communicating with them. Again, your expectation. If you're mission focused and you want to get that your hygiene visit over with in 10 minutes or 15, 20 minutes, it's not going to happen. What's the expectation that you have of yourself, of the parents? Can't roll your eyes and say, I can't believe how horrible these parents are. They haven't brought their loved one to the dentist in 20 years. You have, the expectations have to be realistic and compassionate. We need to acclimate to the environment and participating. A big part of participation with our patients is interacting and taking that time rather than just rotely going through what we normally do. So it does go both ways, and I can't say it enough. The more you're exposed to it, the more familiar, the more secure, and the more confident that you are. So that brings us up to the next question. What about training within the dental programs, both dental hygiene and dental schools? What kind of training do they have? As I have a note here that, CODA has put that graduates must be competent in providing dental hygiene care. This is for dental hygiene. This is hygiene care for the child, adolescent, adult, and geriatric patients with special needs. Graduates must be competent in assessing the treatment needs of patients with special needs. And the intent is an appropriate patient pool should be available to provide a wide scope of patients experience that include patients with special medical, physical, psychological, or social needs. Anyway, that's what CODA says, but very few dental programs have hands-on experience with people with special needs. My experience has been that we have volunteers that go for screenings at Special Olympics on one end with absolutely no training at all, and you go home with that good feeling that you've done something great in the community. And then all the actual formal training happens after you graduate. It's a postdoctoral programs that you go in for special needs where you're doing hospital dentistry and certified for that. So somewhere in between, I think is, that's my thought. What are your thoughts? I'd like to know. I'd like to really see more people feel comfortable with special needs patients. Patty, take it away.
Well, that's where, again, we talked about this because, again, I saw, the same patient population that Helen's seeing now, I saw as a student. And what Ellen and I have talked about is that appropriate? Do you have the skill set or understanding? Because I sure don't remember learning anything about special needs before we saw them. They basically, it almost felt like it's like, oh, they're just special needs. We'll let students see them because they don't have to know what they're doing. And I hate to think of it as being that crass, but yet in another way, I don't know that I'm not correct in that. Ellen?
Well, it's kind of hard to speak on that. I know I had a wonderful opportunity to have the hygiene school down the street come into our
Same
clinic.
hygiene school.
Yes. If 2 students at a time would come in and really had one-on-one training with me and experience seeing the patient that I was seeing that day, and they could observe and look at the health histories and see how complex they were, and to go ahead and interact with that individual. Of course, I'm there, and it's my patient. I'm not giving them off to a student. They are there so that they can observe and I can mentor. And it was a wonderful program. And unfortunately, the powers that be, it is no longer going that route. I would love to continue it or have that come back up again. But yeah.
Do you know why it was
That-
discontinued?
Legal stuff.
Okay. Okay.
Yeah, and that's a good. Yeah, go
We
ahead.
also have in the chat box
I
from
see that.
Lisa. Lisa wants to ask, have you had parents that were not helpful and you had to send them out of the room?
Yes. Yes, absolutely. Which is not an easy thing to do. But again, desensitization goes all the way around. I have one mother currently that I'm working with right now who, a very helicopter mom, right on top of her 28-year-old son who can clearly comprehend what's going on. I got her from sitting right on top of her son to sitting at my desk behind us, and now standing in the hallway. So we're working on her, but we have had other parents. Yes, we say, would you mind stepping out in the hallway? We'll call you if we need you. Absolutely. Some parents do not help at all. They use the B word all the time. Brave. Oh, you're so brave. Oh, and don't be scared. Like, what? We don't use that language. What's so brave about going to the dentist? So it's a part of life. Are you brave to get your hair cut? Anyway, yes, we do, to answer your question.
Thank you.
Terrific. Thank you. Thank you. Moving on.
Well, again, the training programs, anybody have any ideas? What was their training like? Has anyone had anything in their hygiene education that they want to share about that might be helpful for this group?
Apparently not.
No. Okay.
When I was in school, we had what was euphemistically called the Brenham State School. And it was, all different levels of students who basically lived at this facility. And we would have a 2-day rotation. The program was run for at least 30 years by a hygienist with usually a pediatric dentist that was the on-call doctor as needed, who oversaw the program just a few days a week. But it was basically run by the hygienist. And it was my opportunity to see a lot of those kind of patients. But I don't know if they actually do rotations there anymore. But it could be very extreme because some patients wouldn't really let you do a lot, and then some we could use a Cavitron on.
Absolutely, there's a big spectrum. Well, okay, so that brings up a good point. Okay, is this the care they're getting from having hygiene students rotate? That's it?
Well, they would basically be on the schedule, like on a, monthly, or it wasn't just students. No, I mean, there was a hygienist and an assistant that were already seeing them, and only patients that might have been comfortable with seeing somebody new, we would work on.
Sure, yeah. Okay. Anybody have any suggestions on what they would like to see in dental programs, or even in continuing education or certification in working with special needs? I'd like some ideas so that I just know that we're overwhelmed with the amount of patients that we need to see, and I know we haven't even touched the beginnings of it. There's so many people out there that need care and can't find it. So I guess one of my missions is to try to meet that unmet need with access to care for folks with special needs.
Ellen, this is Lisa Simpson. I have a question. As far as like education or CEs, there's so many in just private practice where the patients' parents don't even know that their kids, have some sensory issues or autism yet.
Sure.
And I mean, as a hygienist, I've seen it. I can't tell them that, your child has future issues that you need to, what about something like that? Have you run across that at all?
Not where I'm currently working at, but yes. And that's a very, very good question to pose, because as professionals, if we see a concern and we're working, wouldn't there be an opportunity to maybe refer a child for an assessment? I'm not sure. I mean, because there's a lot of parents want to deny that there's anything going on, that there's anything different about their child, especially with autism or a sensory issue. But yes, you're making a very good point. And just like, okay, if they have strep throat and they come to your office, you refer them back to their primary care physician. Is there some way that you can do this? I work in a public aid situation, so it's real easy for me to refer to someone else in our organization to to have them assessed for something like that. But in private practice, that's a very good question. I don't know.
But it isn't limited to just, I mean, these desensitization techniques that you're talking about is not limited to people with special needs from the traditional on the spectrum. There are people that they've been so traumatized by dentistry that they need to have a desensitization process just so they can come to a dental office.
Absolutely.
So that's part of the reason I wanted you to talk about this. This is not limited to only people with special needs. A lot of these techniques and what you understand and what you've come to understand and learn about special needs populations are very applicable in many, many settings. Would you agree?
For the patient who had just, like you said, is traumatized, and if you get someone finally to actually come in to see you, again, the number one thing is patience. Get to know that patient. Listen to their needs.
Ellen, I hear you saying this, and let's face it, I'm an old hygienist, and we used to do that. I can't tell you how many patients I've seen. One woman in particular had not been to the dentist since her two sons were both autistic, severely autistic, were born. She'd been their caregiver. And she had horrible perio. Her mouth was a disaster. I worked with that woman for hours and hours and hours, but my boss let me do it. Because it didn't matter about the time. It was about treating the patient. And we finally got her to the point that she was comfortable to come into the office and have some treatment done. She eventually, by the way, brought both her sons in.
Wonderful. Okay, so who else has a situation where they could do something like that, where they could take that amount of time with that person who needs it? I'm finding that harder and harder to find, though. You got to keep on a schedule. I had one lady, and when I was in private practice, she hadn't been to the dentist in probably 40 years. And her whole appointment was just, and I think this was the beginning of my calling. I just listened to her, and when she left, and the receptionist asked me, well, what did you do? And I said, well, yeah. And I kind of got reprimanded because I didn't do anything. And what I did, she came back and she finished her dental care. So that's what I did, but they didn't understand that. Like, you spent an hour just listening to her.
But sometimes that's what you need to do. And everyone has sort of lost sight of that. We have to keep on a schedule. We have to do this. So these people are forced out. It bothers me. It bothers me a lot.
Yeah. And
they
I think
should be taken care of, and no one's doing it. Because, it might take too much time. And we lose an hour of production or two.
Right, but who's putting that pressure on, and who's bending to that pressure? I mean, I think that's where it comes down to, is where our lines as responsible care treatment providers ourselves that will bend under that kind of pressure. Because don't we all decide what kind of professional we're going to be and what kind of person we're going to be every day? I mean, I know that sounds very idealistic, and we know I am an idealist, but I really think that that's part of it. It's like the expectation in my clinical office where I worked the last 13 years it was prescribed that I was doing a prophy and I'm doing this. It was actually written on the schedule. I ignored it. because I can't, first of all, how can we know 6 months, 3 months, 10 years, or whatever in advance what needs to be done that day or what's the appropriate care for that day? We can't know until that person arrives and we do an assessment. That
Patty?
whole, yeah.
Sylvia said that there's no billable code for relationship building.
Oh, hey, there you go. That's great. Let's make one.
You know what? Go to the next slide, Ellen. Seriously.
Okay, there
Yeah,
you go.
codes. And there's codes.
Nice segue, Sylvia.
Thank you, Sylvia. Actually, there's multiple codes for it. Who knows what 9920 is? D9920.
I do, but I'm not answering.
It's called behavior management by report. It can be done in 15-minute increments. By report means we are required to write a narrative on it. This code is particularly most like a medical code because it's done in a time-based thing. This is a code that can be used anytime. It takes longer than the usual average amount of time does for the 1330, which is our oral hygiene instructions. In addition, in these special populations, we have dental case management, care coordination, dental case management, or motivational interviewing, dental case management, patient education to improve oral health literacy, dental case management, patients with special health care needs. Those are 4 case management codes that most of us don't even know that exist, but yeah, it is about for building a relationship.
Mm-hmm.
And our time is valuable. Because there is, I mean, I get the emphasis on time is because it's a business, and dentistry is a business that because anybody here want to be working for nothing? No, we all want to be compensated for our time, so the money has to come from somewhere. I'm not saying we have to make these things up, but there are a lot more codes available. I sat with Carol Roselle, who works in another part of Little City where Ellen is, and she basically does oral hygiene, either instructions or helps them brush their teeth, right? Isn't that basically her job description, Ellen?
Yes.
Yeah. I found 37 codes that Ellen could and should be using in just that end of and that's not in the treatment area where Ellen is. That's in a different side. So
yeah, where Carol.
Where Carol is, yeah. It's just that's why this group and this work is so important, because there's so many things that we could be coding, but we don't know the codes exist. We don't know how to make them work, and there's lots of them. But this is a by report code, so it requires a narrative. I'm not telling you a book. We want to write Twitter-style narratives that fit in box 35 of the claims form, which is the tiniest little space you can possibly imagine. But when we do it, it makes a difference. When we document this stuff, because right now we don't know how many people are there that you're even, well, I don't know, Ellen, how are you documenting desensitization?
Desensitization, we're using the D99 code and the oral hygiene code. That's it right now. And, with your help, I'm going to do it properly. I have to be real excited and tell you I finally found the box that I can put my report in, because the report is documented in our clinical notes, but it really did worry me because we went digital, and before that we had an insurance claim form or encounter form where there was that box 35 that we could put our narrative in. And we went digital. I had no idea where to put it, and I found it today. Thank you very much, Patty.
Yeah, so, well, amazing what you find when you look for it. I don't think a claim should leave any dental practice without something in box 35, and the reason why is in the CDT companion, it even says that it is for information to help support claims when there is a connection between what you're doing in your treatment and their general health. Tell me, what are we doing in our treatment at any time that doesn't have something to do with their health or the rest of their body? That's, again, this is what Beyond Oral Health is all about. Everything we do is so much beyond oral health. So we're already at an hour and a half, Ellen. Let's keep moving.
Oh, we're almost done. Okay, so sorry about that. I'm just going to give you some pictures here of some of the things that we do. It's all about sometimes role reversal. We have a young lady here who is treating Andy the alligator. And once she did this, then she was more comfortable getting in the chair. This fellow here, we have no problem doing his dental care, but every now and then he likes to look at our teeth. And this is a 3-person procedure. Here we're using the cordless prophy angle because this gentleman won't sit down in the chair. He's been so traumatized. He'll sit on the edge of the chair and we can do everything we can possibly do for him right there, but he won't sit down. And then here, the last picture on the right here, we have caregivers helping us out with just kind of stabilizing the head. Again, don't do this at home, kids. You absolutely have to be trained. I don't mean to be facetious on that, but yeah, you have to have training to use the restraints. So here's some pictures of some of my happy people. They range from, these are all pretty a lot of these are they started out where they were resistant to dental care, and now they're very, as you can see, very happy to receive dental care. So I love my job. I have that feel-good feeling all the time. When parents are happy and they cry because they found us, I feel like I've died and gone to heaven. So with that, I will say thank you.
And thank you, Ellen, because this is so important. Like I said, on so many levels, I think there's parts that we can all apply no matter where we are in any kind of a clinical situation with the whole idea of desensitizing. Now, there we go. Sorry. I have the slides running at the same time, Ellen. Okay, let me.
Okay, do I need to do anything? Get rid of mine
you're
or
good.
anything?
Nope, I got it.
Okay.
I got it. That's me. That's my slides up, not yours. So,
okay.
All right. So thank you very, very much. Again, I want to thank Ellen. If you have any questions, if you want to connect with Ellen, she has all kinds of links on different places that you can get materials, adaptive things, all kinds of things. She's an insider. She's more than happy to help anybody here. Remind you again, the 23rd, mark it on your calendar. That's our next DCC. Our next Mastermind with Susan is on March 16th. And again, you know how to reach me. We have your CE done. We will be sending those out to you. And remember, you have access to all of the previous Mastermind or study clubs online if you want to take them. Beyond Oral Health shifts your mindset to help you reach your goals and change the future of healthcare. That's our goal. We're doing it with you. You guys are amazing. Thank you very, very much. And everybody have a good night.